It begins as a whisper beneath the skin, a signal too small to see, too quiet to feel, but powerful enough to change everything. This is the unseen war. To understand psoriasis, we first need to understand healthy skin. Healthy skin is constantly renewing itself. New keratinocytes form deep in the epidermis, rise slowly toward the surface, mature and shed in an orderly cycle. But in psoriasis, the system becomes vulnerable to misreading danger. Genes can increase susceptibility. Triggers such as infection, stress, skin injury, or certain medications can help start the cascade. The DNA does not suddenly rewrite itself. The risk was already there. The trigger wakes the immune response, and the false alarm begins. Right now, inside your skin, there's a system most people will never see. It's not a single organ. It's a living architecture. Keratinocytes building walls, lipids filling the gaps, immune cells patrolling the streets, nerves listening at every junction. Every 28 days, the entire surface of your body is rebuilt from below. Cells are born in the basal layer, mature as they rise, and become the protective armor we see in the mirror. Healthy skin does 3 jobs at once. It keeps water in, it keeps microbes out, and it tells the immune system when to stay calm. Your body holds itself together with chemical messages. Cells talk to neighbors, tissues coordinate, organs synchronize. Most of these messages are invisible to you, but they're happening continuously, second by second, year by year. When the system works, you don't notice it. The barrier holds, the skin renews, the conversation hums along quietly. But communication is fragile. One wrong message, sent too loud to the wrong audience, and the conversation begins to spiral. The wall that's been keeping the world out starts to crack. The signal that should fade gets stuck on repeat. This is where psoriasis begins. Not in the skin you see, in the conversation underneath. Cells in your body don't have telephones. They have cytokines, small protein molecules that act like text messages. A cell makes one, releases it. The molecule drifts to its destination. A nearby cell, or sometimes a cell across the body, receives the message through a receptor that fits the cytokine like a lock fits a key. There are 3 ways cells talk to each other. Autocrine. A cell sends a message to itself, a feedback loop. Paracrine. A cell whispers to its neighbors, a few cells away. Endocrine. A cell broadcasts to the entire body through the bloodstream, like a radio signal traveling everywhere at once. Most cytokine conversations are paracrine, local. But when they spill into the blood, they become systemic. Every cytokine message has a built-in expiration date. Half-lives are short, minutes to hours. For a reason. The system isn't supposed to attack indefinitely. When the threat passes, the messages fade. The receptors stop being engaged. The cells return to baseline. In healthy tissue, this is what resolution looks like. In psoriasis, the messages don't fade. They keep coming. The receptors stay engaged. The cells never get the all clear. In healthy skin, messages are brief and local. In psoriasis, the alarm keeps broadcasting. It usually starts small, a patch on an elbow, a spot on the scalp, a scaly line behind the knee. You think it's dry skin. You moisturize. It doesn't go away. It spreads. You try moisturizer. You try over-the-counter hydrocortisone. You try the keratolytic with the strange smell. Each one helps for a few days. Then the patch comes back. A little bigger, a little angrier, a little more permanent. Here's what's happening underneath. The cream is working on the surface. But the surface isn't where the disease lives. The disease lives in a signal, and the signal is coming from somewhere the cream can't reach. Psoriasis runs in families because of a specific stretch of DNA on chromosome 6. The strongest single gene we've found sits in this region. Its name is HLA-C star 0602. Its name is HLA-C star 0602, a risk variant present in many people with early-onset psoriasis. Most people who have it never develop the disease. Genes load the gun. They don't pull the trigger. Something else has to pull it. Strep throat. A scratch that won't heal. Severe sustained stress. Sleep loss night after night. Smoking. Obesity. a new medication sometimes. Each of these can be the trigger that wakes a quiet immune program. In a person with the genetic baseline, that wake-up call doesn't go back to sleep on its own. And once the immune program is woken up, it leaves a mark. Stress can chemically modify the DNA, not the sequence, but the bookmarks that decide which genes are read. Inflammatory genes get an open bookmark. The cell can read them on demand. This is one reason psoriasis tends to become chronic. This is also why just stop stressing is the worst advice you can give someone with psoriasis. You cannot relax away an epigenetic mark. The bookmark is physical. To turn the program down, you have to mechanically intervene, with light, with medicine, or by lowering the inflammatory signal at its source. Now watch what happens after a small skin breach. Cellular debris is released. A peptide called LL37, normally a janitor, binds to the released DNA. An immune sentry, the plasmacytoid dendritic cell, picks this package up. Inside the cell, a sensor evolved to detect viruses misreads the package as one. The sentry sounds the alarm. Interferon is released. The cascade starts. A second cell, a myeloid dendritic cell, wakes up, grabs antigen, and travels to the nearest lymph node. The local alarm becomes a systemic decision. Inside the lymph node, the dendritic cell shows what it found to a naive T cell. A handshake forms. The T cell receives instructions. It's about to be conscripted. The dendritic cell releases a cytokine called interleukin 23. This is the single most important moment. IL-23 doesn't build the cell. It locks in and amplifies the Th17 program. The Th17 cell now has one job: go back to the skin. The 17 cells circulate in your blood. A skin-homing tag tells them to exit the bloodstream when they reach the skin. They go back to where the alarm started. Once at the skin, the Th17 cell releases interleukin 17. IL-17 tells skin cells to divide fast and call for backup. The plaque is the visible result of that command. Psoriasis isn't one disease. There are several recognized forms, and they don't all look the same, don't all behave the same, and don't all need the same treatment. Plaque psoriasis is the most common. 8 in 10 cases, thick, raised, scaly patches on the parts of the body that bend, stretch, and rub. Guttate psoriasis looks like raindrops scattered across the trunk. It often follows strep throat. It's most common in kids and teenagers. Inverse psoriasis hides in skin folds. Bright red, shiny, almost no scale, because friction and moisture wash the dead cells away. Pustular psoriasis brings sterile blisters, no bacteria inside, just dying immune cells. On palms and soles, it's painful. Across the whole body, it's a medical emergency. If you see widespread sterile blisters on red skin, especially with fever, chills, or feeling severely unwell, go to an emergency department. Do not wait for a dermatology appointment. Generalized pustular psoriasis can become life-threatening within hours. Erythrodermic psoriasis is total body redness with peeling. The skin can't regulate temperature, can't hold fluid. This is also an emergency. If this happens, go to an emergency department now. Most people with psoriasis will never see the emergency forms, but everyone with psoriasis should know they exist. Most medical textbooks show psoriasis as bright red. But that's only how it looks on light skin. On darker skin, the same disease can appear purple, brown, gray, or hyperpigmented. The redness can be entirely absent. This matters because psoriasis is underdiagnosed in patients with darker skin. The disease is the same. The biology is the same. The only thing that changes is the visible color. And that has cost too many people too many years. There's another thing to know. After the plaque clears, dark patches can remain for months. That's not the disease coming back. That's normal pigment response. It fades on its own. Don't let anyone tell you the treatment failed. In healthy skin, sensory nerves end deep in the dermis. In psoriatic plaques, those nerves grow upward, closer to the surface, closer to every brush of fabric. every change in temperature. The volume on your sensory input is turned up. When you're stressed, your nerves release substance P and CGRP into the skin. These trigger mast cells to dump their inflammatory contents within seconds. Your skin reacts to your nervous system before any external trigger arrives. This is why antihistamines often don't help psoriasis itch. The itch isn't driven by histamine, it's driven by inflammatory cytokines talking directly to nerves. To stop the itch, you have to lower the inflammation itself. Step 1 of escalating treatment is often phototherapy. Narrowband ultraviolet B, delivered in a clinical cabinet, kills overactive T cells in the skin and slows keratinocyte division. It's effective, it's drug-free, and it requires repeated visits. When phototherapy isn't enough, the next step is often methotrexate, a drug originally developed for cancer chemotherapy. It blocks an enzyme called DHFR. Without that enzyme, rapidly dividing cells can't make DNA. The skin cycle slows. Methotrexate works because keratinocytes in psoriasis are dividing too fast. Slow them down and the plaque thins. The drug reaches the skin through the bloodstream, so it works on all of it at once. Methotrexate is powerful. It's also a blunt instrument. It can lower blood counts, damage the liver, cause mouth sores, thin the hair. It's not safe in pregnancy. You need blood work every few months. For many patients, it works for years. For others, the trade-offs aren't worth it. For decades, this was the ceiling. Light, then methotrexate. If neither worked, there wasn't much left. That's the era we left behind. The era of broad immune suppression. Now we have something more precise. 2 newer oral medications have changed the landscape for patients who can't use methotrexate or biologics. Apremilast, a pill-form PDE4 inhibitor, clears about 30% of patients to PASI 75. Deucravacitinib, a TYK2 inhibitor targeting the pathway we just traced, clears closer to 60% to that same PASI 75 mark. Here is the part nobody puts on the brochure. The newer drugs are not cheap. Methotrexate costs hundreds of dollars a year. The targeted oral options cost tens of thousands. The biologics cost more. Without insurance or a patient assistance program, access is the barrier, not biology. And before insurance approves the drug your doctor recommends, you usually have to fail the cheaper one first. This is called step therapy. It can mean months on a drug your dermatologist already knows isn't right for you. It is the system. It is not your fault. 3 things help. 1. Most major biologics have a manufacturer-run patient support program with co-pay assistance. Ask your dermatologist's office about it. 2. If you're denied, your dermatologist can request a peer-to-peer review with the insurance medical director. These often overturn denials. 3. Ask about a step therapy override based on medical necessity. The system has doors. Use them. Topical treatment has changed too. For decades, the only option was a corticosteroid. Now there are 3 new classes, each with a precise molecular target. Topical roflumilast, brand name Zor-Ev, blocks an enzyme called PDE4. With PDE4 blocked, the cell's calming molecule, cyclic AMP, builds up. The inflammatory program quiets. It's safe to use on the face, in folds, and on children 6 and older. Tapinarof, brand name Vutama, does 2 jobs at once. It calms inflammation and it helps the skin barrier rebuild. Some patients get extended remission after stopping the cream, something steroids could never offer. Topical ruxolitinib, brand name Opzel-Ora, works inside the cell. It blocks a signaling enzyme called JAK. The cytokine knocks. The receptor tries to send the message. The line is dead. In 2026, it's approved for atopic dermatitis and vitiligo. For psoriasis, ask your dermatologist. Let's go deeper. The dendritic cell holds out a fragment of a peptide on a serving tray called MHC class II. The naive T cell inspects the tray. Cytokines whispered alongside the handshake decide what kind of soldier the T cell becomes. Interleukin-23 docks with its receptor on the T cell surface. The receptor has two parts, IL-23R and IL-12 receptor beta-1, and together they activate the next step inside the cell. Two enzymes called JAK2 and TYK2, Janus kinases, light up. They tag a transcription factor called STAT3. STAT3 travels into the cell's nucleus. This is the same pathway that targeted oral therapies aim to interrupt later in this story. Inside the nucleus, STAT3 binds DNA. Inflammatory genes that were quiet now switch on. The cell starts manufacturing the next round of cytokines. The Th17 program is locked in. The T cell now releases its payload. Interleukin-17 drives plaque formation. Interleukin-22 thickens the skin. Tumor necrosis factor alpha amplifies the entire inflammatory environment. 3 cytokines, 3 different jobs, 1 outcome. Skin cells normally take a month to mature. Under this signal, they take 3 to 5 days. They reach the surface unfinished, sticky, piled up. That's the silver scale you see. When the plaque clears, the skin looks normal. But it isn't empty. Tissue-resident memory T cells stay behind. They're dormant. They're waiting. This is why psoriasis comes back to the same spots, and why clearance treatment usually has to keep going. A biologic is an engineered antibody, a Y-shaped protein produced in living cells. It's designed to bind one specific cytokine and neutralize it. It doesn't kill immune cells. It silences a single signal. The first generation was anti-TNF, adalimumab, etanercept, infliximab. They work for psoriasis and psoriatic arthritis. They require tuberculosis screening because TNF helps your body keep TB dormant. Generation 2 blocks interleukin-17, the cytokine right at the keratinocyte. Secukinumab, ixekizumab, brodalumab, bimekizumab, which blocks 2 forms of IL-17 at once. These work fast. Most patients see early clearing within weeks. Generation 3 goes upstream. Risankizumab, guselkumab, and tildrakizumab block the P19 subunit unique to interleukin-23. Without IL-23, the Th17 army can't be maintained. Maintenance dosing is every 8 to 12 weeks depending on the agent. There's a fourth target, interleukin-36. It dominates in generalized pustular psoriasis, the emergency form. A drug called spesolimab, brand name Spervigo, was the first targeted biologic licensed specifically for GPP flares. A single IV infusion can clear pustules within a week. The bar chart of what's possible has moved enormously, from a 30% PASI 75 rate on the older oral drugs to 85% or higher. PASI 90 rates on the newest IL-23 inhibitors. Complete clearance, PASI 100, is now realistic for many patients. Picking the right biologic isn't a popularity contest. It depends on what else is happening: your joints, your gut, your nervous system, whether you're pregnant. Each comorbidity nudges the choice in a direction. Doctors measure psoriasis severity using a score called PASI, the psoriasis area and severity index. They score 4 body regions for area and intensity. The score runs from 0 to 72. A PASI of 10 or above counts as moderate to severe. Treatment response is reported as percentage improvement. PASI 75 used to be the goal. PASI 90 is now the modern benchmark. PASI 100, completely clear skin, is realistic for many patients on the newest biologics. The bar has moved. But PASI only measures what a doctor sees. There's a second score, DLQI, that measures how much the disease affects your life. Sleep, work, sex, relationships, confidence. A high DLQI with a low PASI still means you need treatment. Someone with psoriasis on the hands and genitals can score 4 on PASI, technically mild. but their DLQI can be 22. They haven't slept well in years. The numbers must be read together. Severity isn't just what the camera catches. The treatment map is a ladder, not a prescription. Topicals at the bottom, phototherapy. Traditional oral systemics, biologics, emerging therapies at the top. Each rung is a decision point. Your dermatologist matches the rung to your disease. Comorbidities branch the ladder. Joint pain steers you toward IL-17 or IL-23 inhibitors. Inflammatory bowel disease steers you away from IL-17. Pregnancy points to certolizumab pegol, brand name Cimzia. It has unusually low placental transfer compared with other biologics, so it's often chosen in pregnancy. Before any biologic, you'll be screened. Tuberculosis, hepatitis B. Live vaccines need to be given at least 4 weeks before starting. This isn't bureaucracy. It's the system that keeps the biologic safe across the years you'll be on it. Treat to target. Set a goal, usually PASI 90 by week 16. If you're not there, switch. Don't escalate a failing drug. Don't suffer in silence on a regimen that isn't working. The next biologic might be the right one. Psoriasis is not just on the skin. The same inflammatory signal can spill into the bloodstream, and once it does, it can affect your joints, your heart, your liver, and your mood. This is called the psoriatic march. Up to 30% of people with psoriasis develop psoriatic arthritis. It can appear before, during, or years after the skin disease. Joint damage from PSA can be irreversible if treated late. Watch for these signs. Morning joint stiffness lasting more than 30 minutes that improves with movement. A whole finger or toe swollen like a sausage. Pain where tendons insert into bone. Heel, elbow, behind the kneecap. Lower back pain that wakes you at night and improves with motion. Nail pitting or an oil drop spot under the nail. A first-degree relative with PSA. If any of these are happening to you, ask your doctor about a rheumatology referral. Don't wait. The biologics that treat your skin can also protect your joints, but only if started in time. Cardiovascular risk is higher. Depression and anxiety are more common. Liver disease is more common. Screen for these. Treat them. They're not weaknesses. They're shared biology. What you eat doesn't cure psoriasis, but what you eat can help. A Mediterranean-style pattern, olive oil, fish, vegetables, fiber, nuts, supports the gut barrier and reduces background inflammation. It's an adjunct, not a substitute. Omega-3 fatty acids can shift inflammatory signaling. Vitamin D supports immune regulation. Moderate sun exposure helps in summer, but a sunburn can trigger a Koebner plaque. The dose matters. Talk to your dermatologist. If you carry extra weight, losing 5 to 10% can meaningfully improve your psoriasis. Adipose tissue produces inflammatory cytokines. Less of it means less background fuel. This is the most underused intervention in psoriatic care. Stress reduction and sleep aren't soft. During deep sleep, your brain widens its drainage channels and clears inflammatory waste. Chronic short sleep keeps your inflammation higher. Cognitive behavioral therapy works. So does meditation. So does 8 hours. Together, medication, sleep, diet, stress management. These reach what you can think of as the floor of silence, the lowest sustainable level of background inflammation. Treatment works best from this floor. If you have psoriasis, this is the era to have it in. A diagnosis today is not what a diagnosis was 20 years ago. The treatments are real, the targets are precise, the outcomes are measurable. PASI 90, almost completely clear skin, is now achievable for most patients on a modern biologic. PASI 100, completely clear, is achievable for many. 12 weeks between doses, years of remission. Psoriasis is not a skin disease. It is a signaling disease that shows up on the skin. The plaques are a symptom of a deeper signal. Treat the signal and the plaque follows. That is what changed. If you have psoriasis, you are one of 125 million people on this planet. You are not alone. You are not at fault. And the science finally has the tools to help you live a life around, not under, this disease. Beyond biologics, the next frontier is gene editing. CRISPR, base editing, prime editing. Tools that can rewrite single letters in your DNA. Not the symptom, but the source code that makes some immune systems prone to overreaction in the first place. Gene editing has already cured sickle cell disease and beta thalassemia in clinical trials. For psoriasis, it's not standard care today. The biology is more complex. Many genes contribute. The path is real, but it is not next year. What is real today? The era of broad immune suppression is fading. The era of precision is here. The era of source code repair is being prototyped. The trajectory is real. The timing is uncertain. The direction is clear. From a corrupted signal in a single cell to a system-wide inflammation to a treatment that intercepts one molecule at a time. This is what we know now. This is what you can act on. This is the unseen war.